Hello, good morning friends. Today we'll be discussing about diabetic foot ulcers. So before starting, I would like to thank Chandana Shri Ma'am for sharing the wonderful notes with us. These are very helpful notes for quick revision for MBBS, MS, DNB surgery exams. And the link for the notes is given in the description below. You can download it from there. And without further delay, let's get started. So diabetic foot ulcer, these are very troublesome issues and very tricky to handle, and these need multi-modality approach like surgeons, plastic surgeons, orthopedicians and physician in this manner. So let's see the pathomechanism. So there'll be three types of issues like the neuropathy, ischemia and impaired wound healing. In neuropathy, we'll be having sensory, motor and autonomic disturbances. All these will result in minor trauma, and these overall in time will result in diabetic foot ulcer. And these will also cause foot deformity associated with the altered foot biomechanics due to tendons and ligamental glycosylation, and over time this become less elastic and deformed, giving rise to formations like charcot foot, claw or hammer toes, dislocation of the metatarsophalangeal joint, MTJ, or bunions in this manner. Now we see the neuropathy, sensory. In sensory, we have the distal symmetrical sensory neuropathy, loss of protective sensation. The test which is used is the Semes-Wilston monofilament testing and the testing for vibration sense. In motor, we will be having wasting of the intrinsic muscle of the foot. The छोटे muscles of the foot जो है वो waste होने लगेंगे, which this upsets the balance between flexors and extensor. तो उसके वजह से flexor and extensor muscles का balance disturb हो जाएगा. Then the three common disturbance of the toes, that is mallet toe, hammer toe and claw toe. In mallet toe, there is flexion of the distal interphalangeal joint, the distal most one. Rest is normal. So that will result in hyperflexion of the distal interphalangeal joint, resulting in contraction and spasm of the flexor digitorum longus and rupture of extensor digitorum longus at distal interphalangeal joint. And treatment would be flexor digitorum longus tenotomy, which would be percutaneous or open, FDL transfer to dorsum of phalanx, and DIPJ excisional arthroplasty, that is distal interphalangeal joint excisional arthroplasty. Next is the hammer toe. Here there will be flexion in the proximal interphalangeal joint, and metatarsophalangeal joint there could be slight extension or it could be normal, and rest is normal, that is distal interphalangeal joint. So there will be imbalance among the intrinsic muscles, overpull of the external digitorum longus, as it will be associated with painful corns over the dorsal proximal interphalangeal joint, and it is the most common deformity of the lesser toe, hammer toe. Treatment will be tendon transfer, that is FDL to EDL, and EDL lengthening, extensor digitorum longus lengthening, लंबा कर देंगे, and FDL to EDL, that is flexor to extensor digitorum longus tendon transfer. So this was hammer toe. Now we see claw toe, where we have flexion of both proximal and distal interphalangeal joint with hyperextension of metatarsophalangeal joint. Here metatarsophalangeal joint hyperextension is the primary pathology, that is the main pathology, resulting in the chronic issue, and unopposed flexion of the proximal and distal interphalangeal joint by flexor digitorum longus. Here we'll go ahead with extensor digitorum longus tenotomy, lengthening, or arthroplasty. So other deformities like hallux valgus, where the metatarsophalangeal joint will medialize. Then pes cavus, where there will be caving of the foot arch. Then autonomic neuropathy, which will be having dry skin, decreased sweat or oil gland functions. Now we see the classification of diabetic foot ulcers. So it could be neuropathic foot, where there will be neuropathy resulting in seizure, bulla, callosity, Charcot arthropathy or neuropathic edema. In neuroischemic foot, vascular disease will be prominent with rest pain, ulceration over the margins, digital necrosis and gangrene. Some classification, that is Wagner and University of Texas. Wagner, where is grade class 1 is no open foot lesion. Grade 1 is superficial ulcer, which could be partial or full thickness. Grade 2 is ulcer extending to ligament, tendon, joint capsule or deep fascia without any abscess or osteomyelitis. मतलब अल्सर है लेकिन सिर्फ लिगामेंट टेंडन जॉइंट तक पहुंच रहा है, एब्सेस या फिर ऑस्टियोमाइलिटिस नहीं है. डीप थर्ड में डीप अल्सर विथ एब्सेस जॉइंट इन्वॉल्वमेंट और ऑस्टियोमाइलिटिस, मतलब बोन तक पहुंच जा रहा है या फिर वहां पे कलेक्शन हो जा रहा है. फोर्थ इज गैंग्रीन लोकलाइज्ड, दैट कुड बी फोरफुट और हील. फिफ्थ इज एक्सटेंसिव गैंग्रीन. सो फर्स्ट इज सुपरफिशियल अल्सर, छोटा अल्सर है, पार्शियल है या फुल थिकनेस है. अल्सर विथ involvement of ligament tendon वगैरह. Deep ulcer with osteomyelitis, gangrene localized, extensive gangrene. Then University of Texas classification, where 0 is pre-ulcer or post-ulcer with some epithelialization. 1 is superficial ulcer. 2 is ulcer extending to the tendon. 3 is ulcer extending to bone or joint. So it is simple. It could be added with ABCD features, where A is non-infected, non-ischemic, B is infected, C is ischemic, D is both. Sorry, infected and ischemic. Other classification we have is PIDIS, Sindbad, SAD and IDSA. How do we evaluate these tumors? How do we evaluate these ulcers, diabetic foot ulcers? First is by the culture and sensitivity, which will help us deciding the best antibiotic. Routine blood workup in the form of blood sugar control, glycemic index, etc., comorbidity conditions. Vascular evaluation in the form of Doppler. If needed, we go for CT angio also. Radiology, X-ray and CT scan for osteomyelitis and MRI for marrow involvement. Now we see the management. Management is general initially, the glycemic control, neuropathy treatment and hygiene. Then the debridement, which could be either mechanical in the form of debridement, mechanical rubbing, autolytic, enzymatic, surgical, biological. Dressing, we go for moist wound therapy, negative pressure wound therapy, non-surgical pressure offloading. So gold standard are total contact casts or special footwear which help in offloading shoes with inserts, and orthotic devices. Then we come to surgical offloading, that is ulcer resection, tendon lengthening transfer or exhaustectomy, arthroplasty, limb lengthening and transfer, Achilles tendon lengthening. So it reduces the forefoot pressure. Achilles tendon lengthening reduces forefoot pressure and is used for equinus deformity. If there is additional varus deformity, we go for tibialis anterior tendon transfer from medial to lateral cuneiform or cuboid. So varus deformity will go for tibialis anterior tendon transfer from medial to lateral cuneiform. Others, like we have percutaneous or open tenotomies for toe deformities or toe arthroplasties, metatarsal head resection for plantar metatarsal head ulcers which are involving the bone. Plantar metatarsal head ulcer, we go for metatarsal head resection. Then digital and midfoot amputation through the toes or metatarsal, transmetatarsal reconstruction in the form of VY advancement, toe island, medial plantar flaps, free tissue transfer, revascularization procedures for peripheral arterial disease, and amputation if the tissue is not viable and has a spreading infection in the form of Belloni or Aboni amputation. So this was all about diabetic foot ulcer. Hope it has been understood, and keep studying, keep growing, never give up. Please like, share and subscribe. See you in next video. Thank you.